Hello, everyone. My name is Olivia Jacquemart. I am a QA and trainer with BioQuest Psychiatric and Behavioral Solutions. And today, we are going to be going through understanding and working with the IDD population. So please be aware that this is part 1 of 2. So everyone should be watching this video first before moving into the second part. First, we have to go through what our objectives are. So we would like to understand the prevalence of co-occurring mental illness and developmental disabilities, gain better understanding of adults and children intellectual disabilities and developmental disabilities, otherwise known as IDD, and their needs for mental health services. And then lastly, understand the differences between specific diagnoses and differences between mild, moderate, severe, and profound IDD. Just some statistics here for really what justifies providing an excellent level of mental health care to our clients who have IDD, just across the services ViaQuest provides. So 1 out of every 5 people in the general population will experience a mental health problem in their lifetime. However, approximately 1 out of 3 people with an IDD diagnosis or intellectual and developmental disability will also have a mental illness. And then anxiety and mood disorders are twice as common in IDD clients than in the general population. So very important here to note that there is a higher chance that someone with an IDD will also have a mental illness than in the general population. Specifically, those anxiety and mood disorders are going to be much higher. Some statistics. Some statistics here regarding individuals with disabilities. As of 2021, 28% of adults in Ohio have some type of disability. And Ohio's statistics are actually even higher than the national statistics. So according to the CDC, 27% of adults in the US have some type of disability. Then of these individuals with a disability, almost half of them will have a co-occurring diagnosis of depression. So for Ohio, 49% or 1.2 million individuals in Ohio will have that co-occurring diagnosis. Here are some factors that can contribute to the higher rates of psychiatric disorders in the IDD population. So this includes low levels of social support, such as lack of familial ties, could be poorly developed social skills, as well as a sense of learned helplessness. Learned helplessness being that the individuals have come to expect or just rely on assistance from others. These are, of course, generalizations, so clients with and without IDD may experience some of these, but these do tend to have more of an impact on those within the IDD population. Some more factors include a low socioeconomic level or struggling with the poverty or gaining the appropriate resources, an increased presence of physical disabilities, especially epilepsy. And in that same vein, clients may also be more prone to chromosomal abnormalities, metabolic diseases, and infections. Then there is the heightened family and maternal stress as well. So it can be a lot of strain on family who are often expected to be caregivers. And just some more here. So there is an increased likelihood of central nervous system damage. The central nervous system is the main processing center that manages everything your body does. So from your thoughts and feelings to your movements, there is also an increased presence of reading and language dysfunction, struggling with communication. Then there are decreased opportunities to learn those adaptive coping styles, especially healthy coping techniques that are appropriate for our clients. And lastly, there's an increased likelihood of experiencing early trauma and abuse. So an important note on that too is that those who do have an IDD diagnosis have a higher likelihood of early trauma. And then in that same, or on the same coin there, those who experience early trauma are more likely to have an IDD manifest. So imagine experiencing these factors on top of all of these other difficulties and barriers faced by individuals with IDD, right? So it's no wonder 1 out of 3 of the people with an intellectual and developmental disability also have a mental health diagnosis. Next up, we are going to be getting into some diagnosing and assessing. So in Ohio, the determination for services is made following the Ohio Revised Code. And when looking at the DSM criteria for an intellectual disability, this includes significant sub-average intellectual functioning. It has to have an onset before the age of 18 and concurrent deficits or impairments in adaptive functioning. So these individuals are struggling in multiple areas of their life. In Ohio specifically, the age range is extended to be age 22 in order to be eligible for services. Just some various information here in regard to the DSM-5 and diagnosing an intellectual disability. First, in order to bill for TBS services, a DSM-F code diagnosis is needed for insurance purposes. This means that a primary mental health diagnosis is required, not an IDD diagnosis. The DM-ID2, or the Diagnostic Manual Intellectual Disability, was created to help make the DSM-5 criteria relevant to clinicians working with individuals with intellectual disabilities. It uses the same format as the DSM-5 and lays out diagnostic categories in the same order as the DSM-5. The DM-ID2 provides advice about and considerations for assessing and diagnosing individuals with an ID and coexisting mental health needs. Information is provided in recognizing common behaviors of individuals with intellectual disabilities and in how to differentiate these behaviors from a psychiatric disorder. The DSM-5 also had a change in terminology, which includes utilizing intellectual disability and replacing outdated terms. In the DSM-5, there was also a change in how disorders were categorized, and now there's only one axis versus axis 1 through 5 in the DSM-4. And just a quick note here for all of our VPBS employees, when providing services to our clients, a neurodevelopmental diagnosis cannot be their only diagnosis. So in order to be eligible for a VPBS service, clients must have a mental health diagnosis in addition to the neurodevelopmental diagnosis. So in addition to an IDD, autism, etc. diagnosis. So since we are providing those outpatient mental health services, any diagnosis of an intellectual or developmental disability must be done by the appropriate qualifying professional. And we're actually going to start getting into the types of IDD as well. So like I mentioned, in Ohio, the determination for services is made using the Ohio Revised Code. And intellectual disability and developmental disability refer to distinct but often overlapping conditions. While an intellectual disability refers to a significant limitation in intellectual functioning and adaptive behavior, a developmental disability is a disability that occurs during the developmental period, which may or may not include an intellectual disability. Intellectual disability and developmental disability are used in Ohio under eligibility standards established by the DODD, or the Department of Developmental Disabilities. Eligibility for DD services in Ohio is done by each county board. Some counties will use a more liberal interpretation of the definitions than others, and this can be confusing to mental health providers who work across the county systems. So in addition to intellectual disabilities, developmental disabilities also include individuals who have cerebral palsy, traumatic brain injuries. That's going to be your ASD or autism spectrum disorder. It also includes those with epilepsy, learning disabilities, and other syndromes if they also meet the functional limitation criteria. Some characteristics of an ID or an intellectual disability are impairments of general mental abilities that impact the adaptive functioning in the following areas. First is that conceptual domain. So this includes skills in language, reading, writing, math, reasoning, knowledge, and memory. It also includes the social domain, which refers to empathy, social judgment, interpersonal communication skills. It's going to be the ability to make and retain friendships and any other kind of similar capacities. And then lastly, there's the practical domain. So this centers on self-management, so things such as personal care or hygiene, job responsibilities, money management, recreation, and organizing school and work tasks. For those with an IDD diagnosis, 80 to 85% are diagnosed with a mild IDD. So they have a mild intellectual or developmental disability. They're going to be slower than normal development in all areas and likely to experience typical body functions once developed. The usual skill repertoire includes practical skills, literary skills, tasks of daily living and self-care, as well as social skills. Just a quick note here that as we go through greater levels of IDD, skill deficits do become more significant, so instruction and supports become of paramount importance. Also, as severity of IDD increases, the need for more precise or systematic means of instruction grows. We are going to go through the different levels of severity of IDD and how it relates to this Piaget's stages of development. So, we are getting this information from the article Cognitive and Emotional Capacities of Individuals with Intellectual Disabilities Using Piaget's Stages of Development. This is by Dr. Gentili in Psychiatry of Intellectual Disability. If you would like more information, you can feel free to look up the article and go through it. We have a resource guide at the end of this PowerPoint. However, I will be explaining this more as we go through the next few slides. So here we have mild ID and concrete operations. So Dr. Gentili, cognitive and emotional capacities of individuals with an ID using Piaget stages of development. Those in the moderate to mild range tend to function at the level of concrete operations. So this means that they think logically about concrete events, but may have difficulty understanding abstract or hypothetical concepts. They are not able to use deductive logic, taking a general concept and using it to predict or determine the outcome of a specific event. They may have difficulty describing symptoms and provide subjective data regarding emotions. So they may state that they are scared instead of mad. When working with those with a mild IDD, it may be helpful to have pictorial representations of various emotions to help increase skill set for both use in the therapy session, but also as a take-home set. Once a therapeutic alliance is established, they are typically able to communicate in a very genuine and authentic way. They are less egocentric than the person with more severe ID and more capable of beginning to see things from others' perspective. Generally speaking, those with a mild IDD are often able to work on conflict resolution skills, empathy, and basic communication of needs verbally or nonverbally. We'll look at moderate IDD next, which includes 10 to 12% of individuals diagnosed with an IDD. Those with a moderate IDD will have noticeable delays in all areas, though particularly in speech. They may have some unusual physiology. So, physiology is the way in which a living organism or body part functions. And lastly, the typical skill repertoire of individuals with moderate IDD includes simple communication skills, simple health and safety skills, some self care and daily living skills, and they can have independence within their communities within those familiar areas. Individuals in the moderate ID range tend to function in the pre operational stage of their cognitive development. So they will interpret their world in that concrete and literal manner. In children with typical intelligence, this occurs at approximately 2 to 6 years of age, and language development is a hallmark of this stage of development. For individuals with a moderate ID, it is best practice to avoid metaphors like it's raining cats and dogs, as well as just to avoid sarcasm. These can be confusing to clients with a moderate ID. Essentially, you are saying one thing, but really you mean another. They will have egocentric speech and will see things from their own perspective, not the viewpoint of others. They typically have difficulty in manipulating information and drawing logical conclusions from information. They will also tend to focus on one aspect of an object while ignoring other facets, and will usually have difficulty ranking the importance of various aspects of a situation or experience. That is why Likert type scales are not always useful for self report. An example of a Likert scale can be seen with this question. So, how important is exercise to your sense of well being? Then you would have to select very important, important, moderately, slightly, or unimportant. Individuals with a moderate IDD generally are not able to answer a question in this way adequately for themselves. When completing the GAD 7 in the PHQ 9 or the outcome measures with these individuals, Make sure to adjust how you explain all the questions to better suit the needs of these individuals. Next, we will look at severe IDD, which impacts 3 to 4% of those with an IDD diagnosis. Those with severe IDD experience significant delays in some areas, including may walk late and limited expressive communication skills. Typical skills of those with severe IDD include keeping daily routines and repetitive activities, few complex tasks of daily living or self-care. Social skills can be achieved with support and supervision. Lastly, we have profound IDD, which impacts 1 to 2% of those with an IDD diagnosis. Those with a profound IDD diagnosis experience significant delays in all areas. There are congenital abnormalities present, congenital being a condition or trait that is present from birth. And people with profound IDD require specialized care and intensive support. They will need close supervision, but may respond well to regular physical and social activities. If TBS are involved at this stage, then TBS may be working more with staff or family, so how to support or interact with the client in providing education, coordination of services, things like that. And looking at the stages of development here for those with severe or profound IDD, PHA's sensory motor stage of development is defined as taking place from birth until the development of language. With the development of language, an individual understands the world by integrating sensory information with behavior and actions. Individuals with severe or profound ID have limited to no development of language and couldn't be considered functioning at this sensory motor stage of development. While the history is being taken from caregivers or others, the individual with severe or profound ID can be observed for appearance, relatedness to others, impulse control, their activity level, whether there are voluntary or involuntary motor movement. There's also the expression of affect or their face, attention span, any unusual, ritualistic, stereotypic, or repetitive behaviors, and any external signs of anxiety. Looking at a DD more broadly here, a developmental disability is defined as a severe, chronic disability that is characterized by all of the following. It is attributable to a mental or physical impairment or a combination of mental and physical impairments, other than a mental or physical impairment solely caused by mental illness. Is manifested before the person attains the age of 22, is likely to continue indefinitely. In the case of a person age 6 or older, a substantial functional limitation in at least 3 of the following areas of major life activity as appropriate for one's age. So self-care, receptive and expressive language, learning, mobility, self-direction, capacity for independent living, and if the person is age 16 or older, capacity for economic self-sufficiency. Next up, we are going to be getting into specific neurodevelopmental diagnoses. So we will look at Down syndrome first. Down syndrome is a genetic condition causing a set of delays in physical and intellectual development because of an extra copy of chromosome 21. Cognitively, those with Down syndrome may experience mild to moderate delays in development, and some physical characteristics of Down syndrome include a small head, upward slanted eyes, a broad neck, hearing loss, obesity, and gastrointestinal problems. People who have Down syndrome have increased risks for certain medical conditions, such as congenital heart defects, respiratory and hearing problems, Alzheimer's disease, childhood leukemia, thyroid conditions. And a few of the common physical traits of Down syndrome are low muscle tone, small stature, again, that upward slant to the eyes, and also a single deep crease along the center of the palm. Early interventions in specialized healthcare, speech intervention, physical therapy, and occupational therapy will improve outcomes for people who have Down syndrome. So we will watch a quick video here from Frank Stevens, who is an advocate for those with Down syndrome and who has Down syndrome himself.
Mr. Chairman, and members of the committee, just so there is no confusion, let me say that I am not a research scientist. However, no one knows more about life with Down syndrome than I do. Whatever you learn today, please remember this. I am a man with Down syndrome, and my life is worth living. Sadly, across the world, a notion is being sold that maybe we don't need research concerning Down syndrome. Some people say prenatal screens will identify Down syndrome in the womb, and those pregnancies will just be terminated. It's hard for me to sit here and say those words. I completely understand that the people pushing this particular final solution are saying that people like me should not exist. That view is deeply prejudiced by an outdated idea of life with Down syndrome. Seriously, I have a great life. I have lectured at universities, acted in an award-winning film and an Emmy-winning TV show, and spoken to thousands of young people about the value of inclusion in making America great. I have been to the White House twice, and I didn't have to jump the fence either time. Seriously, I don't feel I should have to justify my existence. But to those who question the value of people with Down syndrome, I would make 3 points. First, we are a medical gift to society, a blueprint for medical research into cancer, Alzheimer's, and immune system disorders. Second, we are an unusually powerful source of happiness. A Harvard-based study has discovered that people with Down syndrome, as well as their parents and siblings, are happier than society at large. Surely happiness is worth something. Finally, we are the canary in the eugenics coal mine. We are giving the world a chance to think about the ethics of choosing which humans get a chance at life. So we are helping to defeat cancer and Alzheimer's, and we make the world a happier place. Is there really no place for us in the world? Is there really no place for us in the NIH budget. On a deeply personal note, I cannot tell you how much it means to me that my extra chromosome might lead to the answer to Alzheimer's. It's likely that this thief will one day steal my memories, my very life from me. This is very hard for me to say, but it has already begun to steal my mom from me. Please think about all those people you love, the way I love my mom. Help us make this difference. If not for me and my mom, then for you and the ones you love. Fund this research. Let's be America, not Iceland or Denmark. Let's pursue answers, not final solutions. Let's be America. Let's make our goal to be Alzheimer's free, not Down syndrome free. Thank you.
Thank you.
Mr. Chairman. Mr. Chairman.
So what Frank is referencing there is that other countries have been genetically testing, and if a fetus is found to have Down syndrome, an abortion may be performed for that reason. However, what Frank is advocating for is people with Down syndrome to participate in research regarding Alzheimer's disease due to the unique genetic makeup. Next, we will look at Fragile X syndrome, which is a genetic condition that causes a range of developmental problems, including learning disabilities and cognitive impairments. Generally speaking, males are more severely affected than females are. Fragile X does not always cause intellectual disability, but most people who have Fragile X do have a mild or moderate intellectual disability, experience anxiety, and display hyperactivity. So we will watch a video here that will explain Fragile X more in depth.
Everything is connected and affected, really.
One, two, oh.
No.
Oops.
Oh, no!
Fragile X syndrome is common. It's not only the most common identifiable inherited cause of intellectual disability, it's also the most common identifiable inherited cause of autism spectrum conditions. It affects as many as 1 in 3,000 to 1 in 4,000 individuals in its full mutation state, but it's far more common again in people who carry the pre-mutation. The most common physical feature of Fragile X syndrome is just how normal and ordinary an individual appears. This is important because people, including professionals, often mistakenly believe that if you have a genetic cause for your disabilities, then you will look different. There are some subtle aspects. The head can be slightly largish and longish, with protruding ears, which often flush with high levels of anxiety or emotion. There might be a high-arched palate, which can affect speech and language, and a longish flattened nasal bridge. The chin can be quite protruding, and usually there's quite widespread lax ligaments, hypermobile joints, flat feet, and occasionally some eye and hearing problems, and perhaps even some heart murmurs.
He has low mobility, he has low muscle tone, double jointedness, that affects the way he walks,
There's a range of common behaviours and developmental aspects associated with having Fragile X syndrome. Intellectual functioning is usually in what we call the mild to moderate intellectual disability range. That's equivalent to an IQ of about 35 to 70.
His communication skills, social skills are affected. His writing, his memory language skills. Everything is connected and affected, really.
Speech and language can also be very characteristic. It can have a humorous or jocular characteristic to it. It can be quite repetitious, and it can have up and down swings of pitch. However, the communication skills are good. There's usually very high anxiety levels, which can often mediate the so-called challenging behaviours. In Fragile X syndrome, there are also often difficulties with concentration span, attentional skills, being restless, and also being very fidgety and impulsive and easily distracted. And if these features are marked, they may qualify the individual for having a diagnosis of attention deficit hyperactivity disorder, or ADHD. Also, individuals, and this is very true of Fragile X syndrome, have multiple marked sensory sensitivities.
It's a different world for him to understand, and it's very challenging for us to understand what he sees, what he feels.
If we got to somewhere where it's new, God forbid if it's dark. I mean, it's not so much now, but when we're younger.
If it's loud.
If it's loud, dark, new, crowded.
Smelly.
Yeah, we'd be outside for ages.
There's no doubt that individuals with Fragile X have raised rates of autism spectrum disorders. So whereas in the general population it's only about 2% who have an autism spectrum disorder, in Fragile X syndrome it may be as high as 20 to 30%. However, it's usually the paradoxical juxtaposition of a friendly and sociable, albeit shy and socially anxious personality in the presence of certain autistic-like features.
Once he gets used to the people, once he overcomes anxiety and the pressure of talking, two-way talking, he's fine with people.
He's beautiful hair, pink ears, pink.
He would kind of hide behind you first, and then he'd make sure he's with you, and bit by bit he'd come out.
And he says embarrassing things.
Yeah.
Well, they're fine if they know them. If they're within their circle, or the family circle, or whatever it is, or they're with me when I meet a stranger, they're fine. On their own, they're not as good with strangers. Well, Jason, I can't say that about Jason because he'll talk to anybody.
I love being around with friends and chatting to them all and chatting to customers and things, you know.
There's a lot of confusion about how Fragile X syndrome and autism relate to each other. Fragile X syndrome describes the cause of the challenges. In technical language, what we call an etiological label. That is the cause, and there may be a range of possible consequences, one of which is autism spectrum disorder.
It's a bit like autism,
It's a bit like autism.
but he's not autistic.
Yeah,
I do
that's
say
right,
that.
yeah,
It's a
yeah.
bit like autism, but he's not autistic.
yeah.
He's very personable, he
Yeah.
gets along with people, he likes to be around people.
Yeah.
There are quite substantial gender differences in Fragile X syndrome. So for males, who are usually full mutation individuals, the intellectual level will often be lower than females. There may be more marked hyperactivity and inattentiveness and more pronounced autistic features. In females, it's often more subtle.
It's a very hidden, a very subtle issue, but it's massive for them, and it's a massive social barrier. It's a massive worry for them in the future.
There's enormous variety and range in how individuals with Fragile X syndrome can present. This depends in part of the level of intellectual functioning, so that those with more severe developmental disabilities may be more prone to challenging behaviours. It's as if actions speak louder than words for that group, particularly if their verbal language isn't that well developed, and that can lead to quite marked frustration, which comes out as behaviour which is problematic for both the individual and others.
If they don't understand him, he will spit, throw things, cups of tea are often being thrown. I've had my fair share of those as well. I've not always got it right.
For more able individuals, there may be anxiety states, there may be mood difficulties, and often it's the emotional trauma of being aware that you have developmental challenges, yet having extreme difficulty in overcoming them.
Howard had a real character, and unlike Ian and Susan, he let people know what he wanted. He let people know what he liked. And I suppose his form of challenging behaviour, if he wasn't understood, was to become quite introverted and start to shake his head and display it in those sort of ways.
It's very unpredictable, so you could have good few weeks and months of really good behaviour, and then things can change.
All of them have got qualities that are far better than me, and Howard is way with people. He just got so many people who adored him like I did. Yeah, love him.
Do you mind me making that? I'm proud of it. Lizzie likes it, don't she?
Current therapies address the needs of a person who has Fragile X. So speech and language, behavior, cognitive development, sensory integration. Medication is also often used to address some of the symptoms of Fragile X. About 1 in 3 people who have Fragile X also have features of an autism spectrum disorder, such as impairments with communication and those social interactions. The Fragile X phenotype, or the set of observable characteristics of an individual resulting from their genetic makeup, includes a long face, prominent ears, a high arched palate, flat feet, soft skin, and other connective tissue abnormalities. Things to look out for include an increase of anxiety or hyperarousal, early risk concerns such as hand or wrist biting, mouthing objects, or hand flapping. When upset, individuals with Fragile X may escalate to task refusal, leaving the area, verbal aggression with imitated phrases that those with Fragile X are hearing and seeing from others. Triggers include forced eye contact, personal space issues, tactile defensiveness, emotional tone of peers and staff, changes in routine, and auditory stimuli. Other contributors are going to be their auditing processing deficits. So delayed emotional processing, a hypersensitivity to negative correction, a poor concept of time, and a cure for Fragile X, which targets pharmaceutical treatments, is undergoing human clinical trials. It will target the underlying biochemical pathway affected by the Fragile X gene mutation. There is a great deal of ongoing research into the use of drug therapies to address the cellular and behavioral abnormalities of Fragile X. Families diagnosed with Fragile X syndrome will be able to benefit from this medical breakthrough. Next up, we are going to start getting into autism spectrum disorder, and we will start with a video.
Noah is a very loving boy, very affectionate towards myself and my husband. Very much a free spirit, loves to run around, scream as loud as he can. He is willing to go with me anywhere that I want to go. He'll go shopping with me, he'll take car rides with me. So he's very easygoing in that aspect. Okay, here we go. Yay!
I would say he's very ambitious in a sense, where now he's starting to try new things and he's very curious.
Look at the light. On. Noah, we brought him to his pediatrician when he turned 2.
I saw a regression because he was doing like waving by and he was saying mama dada at about 1.5 years. And then by the time he was 2, he was no longer doing that.
And that's when we went to the pediatrician to get evaluated.
He was diagnosed as moderately on autism spectrum.
Sit down.
ABA has been the most helpful therapy for us because it was the first type of structural education that he received.
A. H. Yay!
Helps teach him the basics of what being a child is, purposeful play. It just jump-started everything else. I think without the ABA, early intervention, he would have had more difficulties going to school.
Look, it's applied behavior analysis. I use different strategies to get him to behave appropriately. You put your right hand in, you put your right hand up, brush the baby's hair. You try. Good job! Yay! I started working with Noah. He wasn't making nearly as many sounds as he is now. It's a slow process, but I think he's doing great.
He understands what we're saying most of the time. The first change we noticed was his ability to point, his ability to, like you said, use sign, or, you know, when he's prompt, he's able to vocalize what he wants.
What I want other people to know about Noah is that he is a regular boy. He has his quirks. He is different, but when you get to know him and you get to see his interests and get into his world, he's a lot of fun and he's beautiful.
ASD is a complex condition that impacts normal brain development and affects a person's social relationships, communication, interests, and behavior across multiple life domains. It is now an entire spectrum of autism instead of a single condition that just describes the different levels. So there's no longer autistic disorder, Asperger's, childhood disintegrative, pervasive developmental. Those are no longer autism diagnoses. It is now just one autism spectrum disorder. It is characterized by persistent deficits in social communication and social interaction across multiple contexts, restrictive, repetitive patterns of behavior, interests, or activities. Symptoms must be present in the early developmental period. These must cause clinically significant impairment in social, occupational, or other important areas of current functioning, and are not better explained by intellectual disability or global developmental delay. The diagnosis of ASD can now be made in children as young as 2, as well as adults using a combination of standardized instruments. There's a parent review and an observational scale. Diagnostic evaluation typically will involve a multidisciplinary team. So a pediatrician, psychologist, speech and language pathologist, occupational therapist. Genetic testing may likewise be recommended, as well as screening for related medical issues such as sleep difficulties. Some signs and symptoms of ASD include a variability of intellectual functioning. There's difficulties in sleeping, toileting, and eating, immune irregularities, nutritional deficiencies, and gastrointestinal problems. Things to look out for when it comes to early signs of ASD are noticeable delays or abnormalities in language and play, repetitive behaviors such as spinning things or lining up small objects, and unusual interests such as preoccupations with stop signs or ceiling fans. Getting into the treatment aspects of ASD here, the treatment of ASD usually focuses around early intervention with proper medical care, education behavior therapy, language and speech therapy, occupational therapy, and physical therapy. And then the most significant impairments associated with ASD are going to be those deficits in that social relationships and interactions, deficits in communication, but there is a variability of intellectual functioning. So people who have autism often have difficulty with those social relationships, often transitions, communication and language, a perseveration on interests and activities. Dependence on routine is a big one. Routine often will make clients feel safe and secure. And an abnormal response to sensory stimulation, as well as behavioral problems. And when it comes to ASD, we want to get away from this linear spectrum idea and consider this multidimensional aspect to cognition and functioning. People who are considered not very autistic can still experience impairments in certain areas of their life. Since they are only a little autistic, their experience should not be minimized. Likewise, someone can be considered very autistic can perhaps be highly skilled in certain areas. Perhaps they're gifted in math or art or music, but struggle socially. There is no one development profile, and there is a lot of uneven development happening across the spectrum. When it comes to those with autism, it can be very important to help empower our clients, and we can do that by assisting them in building and recognizing their strengths. Some common strengths of those with autism can be nonverbal reading skills, perceptual motor skills or drawing skills, computer interests and skills. They have an exceptional memory as well as visual spatial abilities, and a lot of times music skills. Although some areas of development in a person who has autism are delayed, people who have ASD often exhibit skills in other areas. These intellectual strengths may overshadow the developmental problems that those with ASD experience. Our next video here is showing what it is like to experience a cafeteria with autism.
Today you will sit through a simulation of the differences between the lunchroom of a person without autism and a person with autism. We will begin with the person without autism. Notice here that the sounds and lighting are normal. Next will be the person with autism. You will notice that the lighting will be brighter and the sounds will be louder and will blend together. This is what a person with autism could go through every day, however each case is different. Look around and notice the differences between the two simulations.
So that second part there really was pretty overwhelming, right? So it can just give us some perspective on what our individuals may be dealing with or how they experience the world that's around them. And then our next video here explains our next disorder, Williams syndrome.
Extraordinary gifts, unique challenges, and more than just a few of each. These are the hallmarks of individuals with Williams syndrome. Williams syndrome is a rare genetic disorder which affects approximately 20,000 people in the United States. It is caused by the deletion of 26 plus genes on one copy of an individual's chromosome number 7. Williams syndrome and families of affected individuals encounter major struggles. Individuals born with Williams syndrome share many common facial features as well as a constellation of medical, neurological, and behavioral characteristics. Most individuals with Williams syndrome have mild to severe cardiovascular disorders, often requiring surgery, and many suffer from kidney, bladder, and gastrointestinal difficulties as well. Children with Williams syndrome can experience hypersensitive hearing, feeding problems as infants, developmental delays, poor motor skills, and mild to severe learning disabilities. As they grow, they struggle with things like spatial relations, numbers, and abstract reasoning, which can make daily tasks a challenge. Many adults with Williams syndrome benefit from supportive housing to live to their fullest potential and work primarily in part-time and volunteer positions. Added to that are the extraordinary gifts of Williams syndrome. Unlike many disorders that can make connecting with your child difficult, individuals with Williams syndrome tend to be social, friendly, and endearing. Parents often say the joy and perspective a child with Williams syndrome brings into their lives had been unimaginable, and their special personalities and perseverance help make dreams come true. Individuals with Williams syndrome also have a very special relationship with music. For most, there is a passion for music that in itself can help enrich their lives. For some, the passion blooms into a musicality that far exceeds their abilities in other areas. Adults with Williams syndrome contribute to their communities as both paid employees and volunteers, working in restaurants, at senior centers and assisted living facilities, in libraries, or as store greeters or veterinary aides. No matter what they are doing, they seem to make a special impact and have a unique ability to quite naturally brighten the days of those around them. Please share this video to help us spread the word about Williams syndrome. Visit us at www.williams-syndrome.org to learn more.
Williams syndrome results from the deletion of chromosome 7. So some more aspects of Williams syndrome here are those highly characteristic facial abnormalities, cardiac abnormalities, metabolic problems such as high blood calcium levels, and there's often an associated IDD, which is often mild to moderate in IDD. There are various physiological and mental characteristics, and oftentimes those with Williams syndrome have an appealing face, engaging smile. There's often auditory processing strength in musical ability and facial recognition, as well as have well-developed verbal skills or that cocktail party chatter. Those with Williams syndrome generally have obsessive compulsive characteristics, so taking over conversation that are niche. And then those with Williams syndrome, as they have an auditory processing strength, on the other side, they are unusually sensitive to noise or have hyperacusis. Williams syndrome, although good at that cocktail party chatter and small talk, generally have difficulty forming deep friendships. There are also medical issues and poor visual motor integrations experienced. And then individuals may have various self-injurious behaviors, such as nail biting or skin picking. So individuals that do have this, it can be especially important to monitor any kind of these behaviors. Here we have the phenotype of Williams syndrome. So oftentimes individuals will have a full lips, puffy cheeks, a small jaw, short stature, as well as spinal curvature and slumped postures. It is important to look for those behavioral phenotypes as well. So things we may be seeing from individuals in their youth include anxiety, fears, phobias, inattention or hyperactivity, social disinhibiting. They could be overly friendly and indiscriminate in relating. They could have actual attention deficit disorder or any autistic features. The next video we have is on the details of Prader-Willi syndrome.
Hi, I'm Susan Hedstrom. My son Jaden was born with Prader-Willi syndrome, also known as PWS. In this video, I'm going to explain briefly what PWS is, including how it occurs, some of the challenges of PWS, and promising research into treatments. Prader-Willi syndrome is a rare disorder that occurs in about 1 in 15,000 births. It affects males and females as well as all ethnicities with equal frequency. PWS is a neurodevelopmental disorder. It's caused by the loss of active paternally inherited genetic material on chromosome 15. Infants with PWS may be identified shortly after birth on the basis of a weak cry, hypotonia or low muscle tone, undescended testes in males, and difficulty feeding. Suspected PWS can be confirmed by a DNA test, which detects PWS with greater than 99% accuracy. Babies with PWS typically require an NG or G tube, special bottles, and extended feeding times. Careful monitoring of babies with PWS is necessary since some may experience failure to thrive. It's recommended to begin growth hormone as soon as possible. PWS is a spectrum disorder. Not every person with PWS will face every challenge that PWS can present. That said, here are some of the challenges that people with PWS may face. Hyperphagia is excessive hunger. Sometime after age 2, a child with PWS will start to gain weight very easily and may have a heightened focus on food. Increased appetite usually starts during childhood and can be gradual. Research is currently underway to find treatments for PWS. But for now, controlling the child's access to food is the only intervention available to manage hyperphagia. It can be overwhelming to see the list of challenges PWS may present, But as a parent of a child with PWS, I can tell you, we have hope. Children with PWS can and do grow up to do amazing things. If your child has PWS, there are resources and a community to help you. You can start by downloading First Steps, a parent's guide to Prader-Willi syndrome. Thanks to the research funded through FPWR over the past 10 years, we now have more clinical trials for PWS coming down the pipeline than ever before. The future of our children is full of opportunity.
So those with Prader-Willi syndrome experience hypotonia in utero, which is decreased fetal movement. They also experience infancy with failure to thrive in the first year of life. There's often a weak cry and delayed motor milestones, such as delayed walking until 2 years old. They often may have short stature, failure of ovaries or testes to function properly, hyperphagia or food-seeking behavior, such as hoarding, eating inedible materials, and this often will lead to morbid obesity. Low muscle tone then will lead to exercise aversion. Individuals with Prader-Willi have an average IQ around 70. They have good expressive language skills, though can do skin-picking behaviors. They have variable cognition, so there is a strength in visual processing, though a low tolerance for teasing, and they try to hide overeating. Nurturing tends to get stuck on topic. And next, we will go over fetal alcohol spectrum disorder here. So fetal alcohol spectrum disorder, or FASD, is caused by prenatal exposure to alcohol. Prenatal exposure to alcohol causes an IDD in approximately 10% of all cases. Diagnostic criteria assigned a rating of 1 to 4 for each criteria depending on the degree of abnormality. So 1, impaired growth, 2, facial abnormalities, 3, abnormal brain functioning, and 4, the degree of maternal drinking. Diagnosis is based on a history of prenatal alcohol consumption by the mother, combined with a group of characteristics in the infant. So poor growth, characteristic facial features, and neurological abnormalities. Brain damage typically results in various dysfunctional behavioral symptoms commonly found, including memory problems, difficulty storing and retrieving information, inconsistent performance, so there may be on or off days. There's impulsivity, distractibility, or disorganization. Those with FASD may struggle with impulsivity, distractibility, and that disorganization, inability to repeat instructions, but inability to put them into action. So they can talk the talk, but don't walk the walk. There is difficulty with those abstractions, so things such as math, money management, time concepts. Then there are cognitive processing deficits, so they may think more slowly. There are slow auditory paces, so may only understand every third word of a normally paced conversation. There are developmental lags. They may act younger than their chronological age, and an inability to predict outcomes or understand the consequences. In the absence of an accurate diagnosis, patterns of defensive behaviors commonly develop over time. These are called secondary characteristics of FASD. Secondary characteristics include fatigue, tantrums, irritability, frustration, anger, aggression, fear, anxiety, avoidance, withdrawal. They're shutting down, lying, running away. There could be trouble at home, school, and just within the community. This could even go into legal trouble, as well as drug and alcohol abuse. There could also be mental health problems such as depression, self-injury, or suicidal tendencies. These secondary characteristics can be prevented with proper diagnosis and support strategies. Intervention strategies typically include concrete instructions, consistent messages, repetition, routine, simple tasks, explanation, supervision, and a decrease in stimulation. We will get into communication disorders quickly here, which are commonly seen with those who have an IDD. So first is language disorder. So a person has persistent difficulties in learning and using various forms of language. It could be that they have a low word knowledge. These people may benefit from utilizing pictures or drawings as best ways to listen to our clients. There's also speech sound disorder. So trouble saying sounds clearly, could be hard to understand what they say. They can easily utilize a communication board of any fashion. There's then childhood onset fluency disorder, otherwise known as stuttering. So sounds and syllables repetitions, there's broken words or whole sound repetition. There are then going to be the substitutions, omissions, distortions, and additions, otherwise known as the acronym SOTA. So substitutions, so they replace one sound with another sound. Example, wed for red, soap for soap. It could be dut for duck, or omissions, otherwise known as deletion. So they omit a sound in a word. And this error affects intelligibility the most, making the speech more difficult for the listeners to understand. So instead of play the piano, it's play the piano, or green snake for green snake. They're omitting those other sounds. And then we have distortions. So producing a sound in an unfamiliar manner. So pencil, nasalized, it sounds like a lot of like M, so pencil, sun, some, things like that. It's just distorted sound. And then there's the addition. So inserting an extra sound within a word. So instead of black horse, it could be black horse, or dogga instead of dog. Things of that nature. You're adding that extra sound. And we will look at social communication disorders just briefly here.
What is social communication disorder? Social communication disorder, or SCD, is a developmental condition that impacts a person's ability to participate in social settings, develop relationships, and perform well at school or work. It was previously considered part of autism spectrum disorder, or ASD, but its symptoms now merit a standalone diagnosis. People with SCD struggle, specifically, to shift their communications to fit different circumstances. The following may seem out of sync or inappropriate in some situations: tone of voice, pitch, volume. People with SCD may also fail to use gestures like waving or pointing, talk about emotions, take turns when talking, stay on topic, ask and respond to relevant questions, make and keep friends. In children, early warning signs include delay in reaching language milestones, low interest in social interactions. SCD can occur alone or alongside another condition, like ASD or a learning disability. Screening involves interviews, observations, and questionnaires completed by parents, teachers, or significant others. Learn more here.
So then attention deficit or hyperactivity disorder, or ADHD, can be characterized by these main aspects. So first is that impulsivity, so experiencing difficulty waiting for his or her turn, has trouble waiting until a question is finished before answering it. They can often interrupt or has no insight into danger. There's also inattention, so unusual levels of distractibility, has trouble following directions and finishing tasks, difficulties getting organized, forgets about daily activities, short-term memory problems and forgetfulness, and has a tendency to daydream. And then there is hyperactivity, so squirming, fidgeting when sitting, doesn't stay seated or is very restless, has trouble playing quietly, always on the move, and talking excessively. Then there are specific learning disorders. Specific learning disorder includes difficulties learning and using academic skills regarding slow or effortful word reading, understanding the meaning of the word, spelling, mastering number sense, number facts, or calculation, difficulties with mathematical reasoning, There are 3 types of specific learning disorder, so that impairment with the reading, written expression, or mathematics. Motor disorders here are a separate diagnosis from autism. So developmental coordination disorder, that's going to be things like clumsiness, slow and inaccurate performance of motor skills, dropping things a lot, they're struggling with doing things like riding a bike or using scissors. There's also stereotypic movement disorder, so repetitive, driven, purposeless motor behaviors. This can be handshaking, waving, body rocking, things of that nature. And then there are tic disorders. So tic disorders fall under the category of motor disorders, and there are a few kinds of tic disorders. And some studies have shown that up to 80% of people with ASD may have some type of vocal or motor disorder. So generally, just as ASD is able to be diagnosed early, tics also form in early childhood from 5 to 10 years of age. So the 3 most common times there is going to be Tourette's, which is the most common. There's persistent chronic motor or vocal tic disorder, as well as provisional tic disorder. Next up, we're going to be getting into some quick precautions as well as best practices that you will need to keep in mind when it comes to working with the IDD population. So these are some best practices and things to keep in mind. So first and foremost, obtain records in advance, if possible, before beginning treatment. You want to become familiar with those collateral informants who attend the interview and understand that the assessment interview can be stressful for everyone involved. The assessment will likely take more time, and we want to use language that correlates with the expressive and receptive language skills of that client. That can be so important. We want to make sure that they can actually understand what we are trying to ask or convey to them. And then individuals with intellectual disabilities experience depression frequently, or individuals who do experience depression frequently talk to themselves out loud rather than ruminate silently. And individuals with an IDD may be more likely to experience irritation rather than sad moods when depressed. Angry, aggressive, and self-injurious behaviors may also be displayed by depressed clients with an IDD. And then this is super important. So most clients with an IDD do not generally refer themselves for services. Referral problems are initially presented by staff as noncompliance, temper tantrums, self-abuse, or going off with no provocation. Clients with an ID who exhibit such behaviors are often depressed and have histories of traumatic exposure. All this is to say are that symptoms may be expressed differently across all individuals, and mental illness is a very subjective experience. Some cautions here that you will need to be aware of as you start to implement services with our IDD population. So clients with an ID have taught to be compliant. So we really must constantly reinforce that there is no wrong answer to questions. Many clients in general will give the answers they think we want to hear. And this is exaggerated with the IDD population, given that additional desire to be normal. So they often state that they understand when they do not. So in order to combat this, we need to have them relay the information back to us in their own words. This way we can actually verify understanding. Just be cautious not to put words in their mouth or to avoid any leading questions. However, also recognize that you may need to assist them in describing their experiences. So try questioning statements with things that are, or with options. So I'm not sure if you are frightened or excited, instead of just you seem frightened. And then more cautions when implementing services with clients. So again, it is best to avoid or adjust those Likert type scales, especially with those clients with concrete operational styles or those with that severe to moderate IDD. Clients in this stage tend to focus on one aspect of an object while ignoring other facets, and will usually have difficulty ranking the importance of various aspects of a situation or experience. So that is generally why Likert type scales are not always reliable. So when you're completing the outcome measures with our clients, like the GAD-7 and the PHQ-9 that utilize those Likert scales, make sure to explain all the options in depth to better allow for accurate self-reporting. Just be careful, again, not to lead your client to answer a specific question. And then clients with ID or autism spectrum often have a strong reliance on routine to feel safe. So change threatens their safety, and oftentimes replacement of maladaptive coping strategies is going to be easier than just removal of those maladaptive coping strategies. And then we also want to ensure the assessment of potential medical problems, as pain, for example, can be exhibited as problem behavior, or a UTI can cause disturbances or confusion. Here we do have those resources for you if you would like to look into IDD a bit more. That is all that I have for you today. So please go ahead and move on to part 2 of this training. And as always, if you have any questions, please reach out to your direct supervisor and they should be able to assist you further. Thank you and have a good day.